Welcome to our webinar titled Understanding Integrative, Holistic, and Functional Medicine. My name is Lee Clark, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. It is possible you may lose your connection during the program. If you should lose your connection and be unable to view the program online, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within just a few business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit your question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you finish typing, just hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker today cannot answer any specific questions related to your personal health care. Our expert today is Mikhail Kogan. Dr. Kogan is an associate professor of medicine at the Georgetown University School of Medicine and Health Sciences, and he's also a geriatrician with the GW Medical Faculty Associates. He obtained his medical degree from Drexel University College of Medicine in Philadelphia, Pennsylvania, completed his residency in internal medicine in New York City, and a fellowship in geriatric medicine at Georgetown University Medical Center. Dr. Kogan is also the medical director of the George Washington Center for Integrative Medicine, in addition to multiple research and teaching responsibilities. He serves as an associate director of the Geriatrics Fellowship Program and provides geriatric consults at George Washington University Hospital. Dr. Kogan also serves as the Associate Director of the GW Interdisciplinary Integrative Medicine Fellowship. It's my extreme pleasure to welcome Dr. Kogan. Thank you so much for joining us today.
Thank you, Lee, so much. It's a pleasure for me to be here. I've been giving this talk for quite some time. Point of clarification, I'm only at GW. I think people get confused between Georgetown and GW, totally fine. So I'm gonna go ahead and share my slides. And also, I am not an oncologist, but I've been over the years seeing upwards of about 500 patients a year with cancer. And that has more to do with just the fact that a lot of the patients with cancer do seek out our advices on integrative medicine, and cancer is one of those conditions where a lot of patients have interest. A couple of quick disclosures. So I do co-own and co-operate the practice where I see most of my patients, which is the GW Center for Integrative Medicine. And I do collect royalties from these three books, and soon the fourth one. And some of the information I'll be presenting today is described in these books. And with that, what we're going to cover today, we're going to discuss what actual terms mean. So there's this three large categories: CAM, complementary and alternative medicine, functional medicine, and integrative medicine. So we're going to talk about what that means. We're going to talk about specific biologic, whether they vitamin supplements or cannabis, as they apply for the MDS and aplastic anemia specifically, and also more generally. We're going to look at the evidence for diet and also kind of talk about what is realistic, what is not. And then we're going to touch up on kind of a core aspects of functional medicine, when you not just saying, okay, you have diagnosis, you have MDS, and now take these medications. We're going to look into other potential drivers that have led you to develop this condition, and what can you do to address those drivers, and as the result, will those simply the condition will get better because you're treating what caused the condition, not just the condition itself. So this is the principle of functional medicine. And then we're going to talk about some of the particular wellness modalities that can make a whole difference in the world and can make you feel better. And then also some other additional ideas. And also I'm going to cover some of the reference and some of the key aspects of how do you navigate this complex world of CAM. So these are the definitions from NIH. So the CAM defined, or complementary medicine, is defined as something that is used with, so that's the word complementary. Alternative means in place, and that's why the words CAM are kind of going away, going out of the favor, because we really don't practice this way. The integrative literally means that you're combining anything that is evidenced. So if you're working with an oncologist who's prescribing you the latest and the greatest regimen, the integrative modalities will be something that is evidence, safe and effective and safe to combine with your standard treatment. And that's a formal definition of what integrative medicine is. One important also difference is that in integrative medicine, philosophically, we believe that body has a strong and innate capacity to help itself, to heal itself. And often, instead of giving a drug or some kind of a specific treatment to condition, if we address what's hindering the healing, that the body will know what to do. So that is one philosophical distinction from the Western model that says you have to address the direct disease. So a lot of what we do in integrative medicine is working with the body, with the terrain, as we say, to optimize it, to make it stronger, to combat the illness better. Very high percentage of patients with cancer use CAM. So this is kind of a different specific data, but generally the belief is at least 50% of any cancer patients at some point in their treatment is going to turn to the integrative modalities of some sort. And before we actually start looking at specifics, what I want to discuss is the level of evidence. So most of the time when the patient goes to oncologist, they're going to be prescribed either level 1 or level 2 drug, meaning that there is either a very significant, well-designed randomized controlled trial showing benefit, or some kind of a prospective or retrospective non-randomized trial showing that the given drug is useful for particular condition. In integrative medicine, often we end up with level 3, which is opinion of experts or base case series, or even just level 4, where there is no actual clinical data. All the data comes from animal studies, or even before the animal studies, what we call in vitro, or in the petri dish like studies, or if it's just the traditional use and there is no additional evidence. So we try not to use anything that sits in a level 4, simply because we often end up noticing that when you start researching something that only has preclinical data, by the time you try to show the benefit, you end up realizing there is no benefit. So you have to be very clear as to what particular level of evidence each approach you're using has. So as you will see from all the slides, each slide is going to have a particular level of evidence and also will be referenced. So these are the biologics we're going to talk about. We're going to talk about green tea and the way I think of green tea specifically, and kind of how to make it practical. Boswellia, a whole list of medicinal mushrooms. These are the Asian mushrooms. That's not the mushrooms you buy in the supermarket. You can buy shiitake, for example, at the supermarket, but we're going to be talking about high-grade extracts. We're not going to be talking about what you can buy in a store. We're going to talk about turmeric, as well as curcumin extracts. We're going to talk about melatonin, vitamin K2, vitamin D, and pretty unusual and unfortunately quite expensive approach, which is the intravenous ascorbate or intravenous vitamin C. So let's start with green tea. So green tea has level 2, 3, and 4 evidence, particularly level 2, and it is specific to chronic lymphocytic leukemia. We don't have a direct evidence for MDS. The green tea is obviously a food, and In the trials, it's often used as a food. So this would be measured in the cups of tea per day. When we're talking about green tea in US, we're talking about both food, but also supplements. So yes, you can obtain green tea in a standardized capsules, and the standardization is done to something called EGCG, which is an active ingredient in green tea. When we're talking about CLL, which is not what we're talking about today, but for CLL, the protocol is upwards of 1 to 2 grams of EGCG. We don't have that specific data with MDS. And so I generally recommend that people do take it as a green tea, as a drink. And I recommend something called matcha, MATCHA green tea that is organic. And you can buy it easily on Amazon or in any store. It's pretty popular now. Matcha is a powder. So in contrast to sipping a green tea from the cup when you simply put the leaves, just like that on a teapot. Matcha comes in basically a powder that you can take a scoop or a teaspoon and mix it with a cup of hot or cold water. So what we know in terms of the data, if you look at all hematologic malignancies, people who consume at least 1 cup of green tea a day has a significantly lower risk. This is one of the better data that we have. What we don't have the data for is to whether or not you can, let's say, take 2 or 3 or 4 or 5 cups of green tea a day, and that's going to be direct treatment for a particular form of MDS. Now, what's important is that there is a lot of misinformation, and often you hear from even oncologists saying that you should stop all the green tea during chemotherapy. That is completely misguided. I would say that if you're taking a very high concentrates of green tea in the form of capsules or powder, not much, just more concentrate, you probably want to make sure that the particular treatment you're on will not have interactions, but it's highly unlikely. And I usually am not worried about that. So again, as I said, try to get organic matcha. And if you are going to take a supplement because for whatever reason you absolutely dislike the taste, and the taste is pretty strong, this is actually how traditionally green tea is taken. It's mixed with a very small amount of water, and then more water is added, and the drink becomes very strong, very potent. It's not bitter, but it has a very unique and specific taste, so you need to like that taste. Tea absolutely must be organic because otherwise it's very heavily treated with pesticides. So, and it's really not a good idea, as you'll see in a future slides, and actually I'm going to be talking about all foods organic in a little bit, and you'll see the reason for that in a minute. So if you're going to end up taking it as a supplement, do get capsules that are usually 300 to 500 milligram and take it 1 capsule twice a day. That will probably be roughly equivalent of 5 to 6 cups of tea. So that gives you some idea as to the potency of that. Boswellic acid, acetate, or just Boswellia, is also known as the frankincense. Literally, that is the frankincense. So if you ever seen it as resin, and that's what is actually used medicinally, but also lower grades of this are used for ceremonial purposes, of burning of the incense of frankincense. It actually induces apoptosis in several lines of human leukemia cells, but we don't have even grade 2 here when they have grade 3 and 4. But Boswellia is very safe. It's historically, traditionally has been used as a food. Yes, you can literally chew on this, and as an anti-inflammatory, it's very effective for example, for arthritic joints. So quality is very important. There's a lot of really good Boswellia on the market. And often what I would do is patients who have ongoing inflammation induced by the cancer treatment, I would often recommend this at the high dose for a couple of months while we're waiting for the inflammation to subside. So this is where we have level 1 evidence. So yes, certain mushrooms, particularly turkey tail and chaga, contain a high-grade evidence. No specific evidence for MDS, but for multiple different cancers, we have large controlled randomized trials showing benefit. Most of these trials come from Europe or Asia, so we don't really have that level of evidence in the US. And that's why most of the oncologists in America do not recommend these preparations, because the data is not really available on the American population, the Americans who also treated with a standard of care in America. This is the list of mushrooms. So reishi, agaricus blazei, or we know it also as ABM, Coriolus vesicore, which is commonly known as Asian turkey tail. Shiitake. Shiitake is easily, and maitake, you can obtain them in the supermarket. In fact, maitake, if you're a mushroom hunter, like I am, you can actually go right now. We're in October in Eastern Hemisphere. If you go on the East Coast, you should be able to, if you know what you're looking for, to find them in the forest. Now, probably not recommended if you're not trained in this, but you can definitely go to your supermarket and buy it. Now, it takes a lot of shiitake and maitake to have any medicinal benefit, so usually we don't recommend it to eat it for medicinal purposes. You really have to get high-grade concentrates, and this is where it gets a little complicated. You really do need to use mushrooms with a professional guidance, because not only protocols are complicated, but also the quality of the products here is critical. There are lots of more products on the market, and most of them are not good. Because the way the extracts have to be made have to be very specific. Low quality products and non-organic mushrooms must be avoided because they can be quite contaminated, and also the extracts could be very poor quality. So in contrast to that, turmeric is something, or curcumin is very easy to take. So curcumin is an active ingredient in turmeric. Here we have level 2, 3, and 4. Including observational studies on MDS that have been done, although I'm not going to present those because I don't think they're not controlled. What we know about curcumin, it's a very potent downregulator of COX-2, kind of similar to non-steroidal anti-inflammatory, similar to Motrin or Celebrex. It also has a lot of other pathways of treatment. So it is even known to be what we call chemosensitizing. So there's been studies showing that if you take turmeric while you're on a particular chemotherapeutic drug, you're potentiating the impact on a cancer. So it's a good thing. If you're not going to take a teaspoon 2 or 3 times a day, or a tablespoon once a day of turmeric, because that's pretty good amount of powder to take, and it's going to make food taste very strongly, you would need to take about 500 to 1,000 milligrams of a concentrated extract twice a day. If you're going to use turmeric as a food, which I think is ideal because it's a lot cheaper and also a lot easier to obtain organic on Amazon, there are plenty of choices. And also it makes the food taste very good. But if you're, for whatever reason, really do not like to take the powder because of the taste, you're probably going to need to identify a practitioner who can guide you on which exact brands to take, because there's a lot of brands and many of them are not good. At the very minimum, you want to look at the standardization. It has to be standardized, ideally at the minimum of 20 or 25% concentrate, and specify that on a label, and also to be from an organic source. Similar to teas, turmeric can be very heavily contaminated, especially the ones that are coming from India and China. You have to be very careful with the origin of it, where it's coming from. So as I mentioned, it is a chemosensitizing agent. So these are the agents with which, when turmeric is combined, it actually enhances efficacy of this agent. So it's actually in some parts of the world, particularly in India and some others, sometimes it's used as such, so to improve efficacy of chemotherapy. So this is some of the medications where it's been studied. And also at the same time, interestingly, it tends to protect our own cells from being affected by chemotherapy via this NRF2 pathway. Let's move to melatonin. Melatonin is one of few products that has level 1, even though there is no specific MDS data, but we have data in certain types of lymphomas, leukemias in a controlled setting in randomized controlled trials. It is a sleep hormone, but it's way more than that. So the melatonin is much more complex molecule. I'll show you some of the pathways on the next slide, but it appears to have a very potent antioxidant impact. And this is important because as a strong, potent antioxidant, you do want to make sure when you are taking a medication, chemotherapy, that you discuss this with your oncologist, because you could have some interactions with melatonin. Practically, we're not really seeing that, but the concern is that if you take a strong antioxidant together with pro-oxidant molecule, that you may end up decreasing efficacy during the treatment. So often I would recommend melatonin after the chemotherapy is finished. And the typical dose is 20 milligrams at bedtime, but you have to start a lot lower. Most people will start somewhere between 2 to 3 milligrams, definitely not more than 5 milligrams. And you titrate it gradually over several weeks. So melatonin has multitudes of action. I mentioned it is an antioxidant, so it decreases the oxidative stress. But it also enhances apoptosis in all the cells in senescence, so in old cells, but also in cancer cells. It has an immune enhancing effect, and it also has anti-hormone effects on some cancers, so decreasing angiogenesis and also decreasing stimulation of several hormonal cancers, including breast and prostate. So it's actually quite well understood molecule. And in contrast to some other supplements, the benefit here is melatonin, very cheap, easy to make. Here, I don't really care about the quality. The problem is to get 20 milligram dose may be a little tricky. You have to actually look. There are only a few brands that make such a high dose. Most of the time when you go to a store, let's say Whole Foods, you're going to find somewhere between 3 to 5 to 6 milligram tablets or capsules. So if you're buying only 3 milligrams, you're going to have to take too many capsules. Sometimes you can find 10 milligrams and take 2, but there are some brands that make 20. So moving on to the vitamin K2, in my opinion, this is the most important supplement for patients with AA and MDS. And here we have a level 1 data on MDS. In fact, to the point that in Japan, for example, vitamin K2 is quite commonly used as a standard of care together with other approaches. So what is vitamin K2? So everybody familiar with vitamin K1 that comes from vegetables and that is made, that is critical for clotting. Vitamin K2 does not involve in a clotting, but it's really an essential hormone for muscle and bone health. The deficiency of K2 leads to osteoporosis and to multiple different cancers of the cells that specifically live in the bone marrow. So K2 seems to be critical for the muscle and bones. So that's what to remember. It's also critical for heart function because it's a muscle. Similar to vitamin D, again, as I mentioned, it's a hormone. It's really not a vitamin. It's just we're labeling it vitamin, but it's actually a hormone. And it has a very strong anti-apoptotic effects on the normal cells and pro-apoptotic effects on the MDS models. And also in, as I said, in the humans. And there's been actually several trials. I think I'm showing you 1 or maybe 2. So this is one old study. It's now at this point more than 20 years ago. This was an uncontrolled study where the 70% of patients had a response to a high dose of K2. And there was an actual improvement in the hematologic improvement by the data. So this is a phase 2 single arm prospective trial. This is a much later study, so this is 2010. So patients with MDS with refractory anemia and cytopenia were given K2 of 45 milligrams. This is very important. I just want to pause for a second. There's 2 types of vitamin K2. There is MK4, which is melatonin, and then MK7. And for the osteoporosis, for the bone loss, and the much more common on the market is going to be able to find MK7, so vitamin K2. Sorry, MK7. That is not what's been studied. The Japanese studies and other studies that have been done on the K2 has been done on vitamin K2, and it's a lot harder to find. The most important point is when you're looking for it is going to be able to find this exact term, menatetraenone, and you have to look on the label. You also can be guided by the milligram because the MK7 is going to be in micrograms. So quality is very important. Again, only MK4 has been studied, but you're going to majority of products are found out there going to be an MK7, and it's not a cheap product. Plan on spending $60 to $100 on the right product. We don't know about side effects, but we'll recommend always combining vitamin D with vitamin K2 because there's a potential competitive inhibition. If you just take vitamin D, you may theoretically decrease of amount of available K2 because they go through the same receptors. Naturally, I forgot to mention, K2 is made in our own gut by our own bacteria. So things like antibiotics or certain other medications actually going to block our own production of K2. Same goes with multiple different chemotherapeutic agents. So it's actually quite important because you can't really eat K2. It does not come from any foods. There's some trace amount in certain vegetables. It's not anywhere near what the body needs. So restoration of the normal gut microbiome or taking an exogenous supplementation with a supplement is basically essential. And you don't need to worry about clotting if you're on Coumadin. I still ask patients to recheck the INR, but I've never seen it being impacted by K2, so I don't think it's an issue. Well, vitamin D. Vitamin D in cancer is a very hot still topic of research. In MDS, we don't have direct data. We do have very large uncontrolled prospective studies showing that patients who have a higher amount of vitamin D in their blood tend to have a lower risk of all cancers. What's not clear is whether fixing that low level is going to lead to decreased cancer or to treatment of the cancer. So unfortunately, I would say it's hard to say all these small studies showing some possible benefit are very difficult to translate. So this is a kind of a long list. Now, this actually MDS studies, but again, none of them are controlled. So how to put this all together, it's a little difficult to put together. But long story short, I think it's pretty obvious that given what we have and given the fact that it's relatively safe, that the practical approach to vitamin D is to get the level up somewhere between 40 or 50 to 80, which usually requires taking some extra doses here and there. I don't recommend taking very high doses like the 50,000 once a week. That seems to be actually potentially problematic. There's a growing data of evidence showing it's actually maybe harmful. And the thinking is that usually we are in the sun daily and our skin limits the production of vitamin D to about 10,000 units per day if you just go in the sun for hours at a time. And there's a block where you can't produce a lot more than that. And so in the studies that were looked at taking heroic doses, 50 or even 100,000 once a week or once a month or something like that, actually produced uniformly very negative results. In fact, there has been several studies showing increase in fractures and even increase in mortality. It's very unclear why that would be or sort of what to make of this data. But I think for the abundance of caution, I never recommend vitamin D in an irregular doses. I recommend it daily at the lower dose, not to exceed 5,000 units a day usually. On a rare occasion for a couple of weeks when you're fixing the deficiency, I would give 10,000 units a day. But then I would quickly, once the level reaches this, I would drop sometimes even below 5,000, depending what I feel that each patient is going to be needing. So this is one of my favorite topics, mostly because I have seen a lot of good responses to intravenous vitamin C. We don't have direct level on MDS, but we do have small control studies on the use of ascorbate, high-dose ascorbate intravenously for other cancers. It's quite safe. By the 2008, we had over 1 million documented infusions. We're probably upwards of 50 to 100 million infusions in US alone at this point. There's only one contraindication, and that's a G6PD deficiency. There is 0 interactions with any other chemotherapeutic drugs. And most of them get chemosensitization, so most of them become more effective. In fact, most of the studies showing that when you take intravenous vitamin C and add it on top of a chemotherapy, you have an additional boosting effect and patient's quality of life improves. So you have more cancer cell killing, but also less side effects of the agents used, standard agents used. The mechanism of action, it produces hydrogen peroxide, and the hydrogen peroxide from the blood diffuses into the cells, and the cancer cells universally lost capacity to handle that. So they do not have the enzyme called catalase to break down hydrogen peroxide. And that's what actually works. Now, people always ask me, well, can you just take hydrogen peroxide intravenously? No, you cannot, because it will not cross into the cells. It kind of will be neutralized in the blood. And for the leukemias, lymphomas, there was a belief that that's effective. But what we actually know is that you need to make hydrogen peroxide both extracellularly and intracellularly. And the only way to do this is to have to deliver some biologic agent, prodrug, we call it, inside the cells. And that's the role of vitamin C high dose. And no, you cannot eat enough oral vitamin C, no matter who tells you what. The idea that liposomal oral vitamin C can be taken in sufficient amount is a lie. It's a fallacy. It just doesn't do that. You have to do it intravenously, and the doses are somewhere between 25 to 100 grams per each treatment. So if you try to take 100 grams orally, you probably will be on the toilet for a day or two with a constant diarrhea. So our own rate of absorption is quite limited, and excretion is very fast. So there is no biological plausible mechanism to raise serum level with oral or sublingual form of vitamin C intake high enough to be able to achieve this effect. So unfortunately, this will always remain to be an intravenous treatment, which obviously makes it expensive, and unfortunately, insurances do not cover this approach. So we personally treated, actually at this point, thousands of patients with different hematologic malignancies. And the biggest effect we are noticing is a better tolerance to chemo, not necessarily survival. I think survival is a little hard to judge based on obviously many different factors. So, and we have a lot of patients. We published several cases even showing the prolonged survival, so we presented them at the different meetings. And as I said, it's quite expensive. It could easily nowadays, it could even be more than 200 with inflation and increased cost of supplies. And it takes a couple hours, so it's a complex treatment. It's not for everybody, but we do have a lot of patients requesting this. Other supplements to consider. So fish oil, very potent anti-inflammatory. It's very conflicting evidence for patients with cancer. It may improve some side effects of chemo and slow down weight loss. So we often use it as a part of the kind of general support treatment when we worry that patient is losing muscle mass, losing weight, and generally in such a state of high inflammation that we're trying to control it, and the fish oil there could be quite beneficial. Mistletoe injections under the skin and also intravenously is a rapidly gaining popularity in US. In Europe, it's about 30% of all cancer patients get this treatment. In some parts of the Europe, particularly in Germany and French, it's actually often covered by their insurance. So it's considered to be kind of a complementary standard, if you will. In States, we only have a current double-blind randomized trial going at Hopkins. Unfortunately, you cannot join it. That trial has been closed for recruitment. I believe that they're going to be announcing results in upcoming year or two. Hopefully, the pandemic had slowed down recruitment. And no, it's not a hematologic malignancy. It is stage 4 solid tumors only. We've been using it at this point for several years. We've only seen maybe one patient with MDS who tried it. So I think that we really can't speak to that much. But overall, we're seeing kind of a parallel data what they're observing in Europe. So people tend to live longer, and the quality of life improves quite significantly, even though the actual modality or actual mechanism is immune stimulation. And sometimes people have flu-like symptoms, which could for about a day or two put people kind of out of commission. They can feel pretty sick. But once that acute flu-like symptom of immune stimulation subsides, people often feel better. And as I said, there's one particular trial, well, there's more than one trial, but they're all under the same leadership. There are lots of other supplements we could discuss: glutamine, acetyl-L-carnitine, alpha-lipoic acid, probiotics. And none of them really directly treat any tumor, but they could be very beneficial if you're prescribed heavy chemotherapy drugs, especially the ones that are toxic for our intestinal tract. So these are the nutrients that tend to be helpful there. They could minimize the fatigue. They could prevent or even treat diarrhea in case of probiotics. Ginger is a wonderful anti-nausea alternative. I highly recommend it to a lot of patients. At the very high dose, ginger can have some liver interactions and blood thinning effect, but you need to take so much of that I never really worry about. In practicalities, those interactions we're not seeing them. And then, of course, this whole topic of medical cannabis for different cancers, including MDS. Well, we don't really have much of the data. It's actually incorrect just to say that it's only level 4. We do have at this point level 3, and for brain cancer, we now have level 2. And for brain cancer, we actually now have level 1. It's just it's not truly level 1 because it's too small of a study to call it level 1. Level 1 is really a large control trial. This was just a small control trial. But we're likely going to see more studies on the effect of medical cannabis directly on. I do want to know that in petri dishes, there's a very potent activity, including MDS, and I think that is a valuable information. We do see a lot of data and a high level of potency for cancer-related symptoms. For pain, for nausea, this is level 1. For insomnia and anxiety, it's a level 2. And I would say for pain and nausea and for palliating those symptoms, I would say cannabis is probably safer and probably more effective than any other existing medications, and definitely more patient-centered. Patients prefer it over all other medications. And even if patients do get quote-unquote side effects of euphoria, for a lot of people, they don't consider that a side effect. Cannabis can actually have true side effects like dizziness, lightheadedness, etc. But when it's applied medically and not smoked, but rather taken sublingually or as an edible, like a capsule, the side effects towards the respiratory tract are obviously non-existent. This data is based on a very robust assessment. So this is 2017 National Academies of Sciences and Medicine report. You can find it quickly online. It's available at no charge directly on NAS website. And what this concluded is that there is a grade 8-1. So this is conclusive or substantial evidence that cannabis or cannabinoids effective for treatment of chronic pain and antiemetic in treatment of chemotherapy-induced nausea and vomitings. And this is for oral cannabinoids. So smoking it will help, but the evidence is less for that. And so this is quite an important finding. Since 2017, what we've observed in terms of data, this continues to stay the course. There's still even more studies, but now we've seemingly added more data on insomnia, more data on not just on pain related to chronic pain, like say fibromyalgia, but also actually specifically cancer-related pain. There's more data on that. And this is one large cohort assessment in Canada that showed that in over 3,000 cancer patients, the use was almost 50%. And basically, 1 in 8 respondents identified at least one cancer-related symptom for which they were using cannabis. So, and then this is the US data. Excuse me, this is the US data that basically showing that in a state with legalized cannabis, the rates of use across the broad subgroup of patients with cancer was much higher, and cancer patients desire but are not receiving information about cannabis use during their treatment from oncology providers. Interestingly, Oncologists are one of the few groups of physicians who almost uniformly believe that the cannabis is effective and helpful for treatment of multiple different cancer-related symptoms. More than 70% of oncologists believe that that's the case as of 2020. This probably has to do with the fact that in a lot of cancer patients using cannabis, and oncologists are using to hear stories from their patients saying, yep, it helps me with whatever. I also find it quite effective for a certain types of cachexia when the cancer induces significant weight loss. It doesn't work uniformly, so it doesn't work universally. And I actually think that the best combination of cannabis for cancer-related weight loss is a combination of THC, which is the psychotoxic or psychoactive form. The actual high that people get from cannabis comes from THC, but also this molecule called CBG or cannabidiol. And the CBG can be purchased without getting medical cannabis card in every state, not just in the 32 states that have legalized medical cannabis. So let's, in the last maybe 5 to 10 minutes, let's talk about other topics. So let's first talk about what should you be avoiding and what should you be cautious with when, especially when you're getting a treatment that is any kind of chemotherapy or biologic agent. So first of all, with chemotherapy, you have to be very careful with taking a lot of oral antioxidants. I mentioned melatonin, but also vitamin A, E, and selenium should not be taken for long periods of time. And especially oral vitamin C at high doses. Remember, the intravenous vitamin C is pro-oxidant. So let me just be clear. When you take vitamin C orally at low dose, it's an antioxidant. When you take it intravenously, it's basically chemotherapy. It becomes pro-oxidative. And that's what a lot of, even some oncologists don't understand the difference. Because the intravenously, it's a pro-drug. In itself, it doesn't do much intravenously. It causes formation of hydrogen peroxide, and the hydrogen peroxide is the drug, not the vitamin C. You also want to make sure you almost never buy retail multivitamins. They're poor quality. They often contain preservatives. The levels of nutrients are usually low, but levels of antioxidants is usually high. So you want to be careful staying away from those. Learn to evaluate quality and claims, consumer reports, or whatever the high quality data set that analyzes this product is probably a good way to go, or just talk to your provider. Many integrative providers will have their own preferred brands and products, and that's much better way to go because those professionals tend to evaluate those products in the way that consumers have a hard time do so. Trusted online resources, Natural Database, that's the actual name of the database. You may be able to get at least some trial version at no cost, or if you have access through the library, many libraries have that. That's one. But also other Hippocrates, which is a standard medical grade drug database, has some of the information on supplements as well. But of course, I would recommend that if you can have access to an integrative provider, that's probably, or naturopathic doctor, that would probably be a much better option. And definitely avoid advices by clerks and salespeople. They obviously have financial bias, and often they're not trained appropriately to know about your condition or to be even able to provide a balanced recommendation. So let's talk about diets next. So plant-based diet, vegetarian diet, level 2, 3, 4, weak positive at best. I have a big concern with them because often they're really difficult to achieve adequate amount of protein intake. For most cancer patients, the amount of protein should be taken minimum 1 gram per kilogram of your body weight. So for the average person who's 70 kilos, that means you have to take 70 grams of protein. Gets a little tricky. You often will need to supplement with a protein powder or protein bar to get that level of protein. High fiber intake, generally very good for health, but there's really no data on cancers. And then there's a lot of really specific diets. So there's at best, there's level 3 and 4, and often very conflicting: macrobiotic, Gerson, Gonzalez, ketogenic. So I would say that none of those really been evidenced enough for us to spend time on this, but I just want you to be aware of those terms. And I think the sensible approach is cutting down animal protein. High animal protein has been linked potentially due to the excess of methionine to higher risk of cancer. So we're limiting animal protein to some reasonable number of portions per week, relatively high in greens and some fruits, and basically really important, avoid dirty foods. So this Dirty Dozen Clean 15, you can get that information from EWG, Environmental Working Group. It's a wonderful resource. There's also a great book by academician Ali Cohen called Non-Toxic, which came out a couple of years ago, which is a very comprehensive review of toxins and how to track for them, how to find them in your house, in your environment, and eliminate them. And the Dirty Dozen is basically, there are 15 or 12 foods that, no, 12 plus 3. So there's 15 very dirty foods. I mentioned teas and coffees, but there's a list of others. And then there's also Clean 15. So you can have a list of foods that usually have a thick skin, like, for example, bananas or oranges. Probably doesn't matter what quality you get, because you're going to take the skin off, and inside the fruit or the vegetable is probably going to be relatively clean. And the reason is, you'll see in a second why, because actually non-organic foods can cause toxicities, and we do know that those associated with MDS. So pay attention to gluten sensitivity. We're not talking about celiac disease, but gluten sensitivity is a very real thing. It increases systemic inflammation. If you don't know your reaction to gluten, it's really essential to try to address it. Definitely genetic detoxification problems, particularly we're talking about MTHFR, but there are other mutations. This is where the genetic testing comes to play. We're not going to be able to spend time on this, but the particularly issues with methylating folic acid is very important, because patients who have these mutations tend to do worse with any cancers, and they really need supplementation with an active form of folate. So a little bit about the gluten. It is evolutionary. It's a relatively new food. Humans have been eating gluten-containing foods only for about 10,000 years or so. And gluten is in the storage of protein of cereal and mostly all kinds of different gluten-containing grains. And it's definitely resistant to the stomach acid and proteases, so it ends up being triggering our allergic reactions as the protein more commonly than many other proteins that our body can quickly digest. So the evidence linking gluten to cancer is level 2, 3, and 4, no specific evidence in MDS. And treatment is usually gluten-free diet, and you can also optimize digestion by taking probiotics, zinc, fish oil, and glutamine for about 6 months. And blood tests are standard, but I don't recommend them, because you just can do the gluten-free diet if you have any possible concern. And the possible concerns is usually if you have any of those symptoms are listed there, and you've had them for a while, and if you eliminate the gluten for, say, 6 weeks and you start feeling somewhat better, you should continue with a gluten-free diet for 6 months. And by no means presence of or absence of intestinal symptoms mean you don't have the gluten sensitivity. It's actually less than 50% of patients with gluten sensitivity going to have any intestinal symptoms at all. So the detoxification can be assessed. There is a variety of different tests now easily available. This is one. And why it's so important? Well, because there's a whole slew of toxins linked to MDS. I'm now, in most of my cancer patients, especially MDS and all hematologic cancer, I assess for all these toxins. We now have easily available and relatively inexpensive tests. We're also seeing beginning of insurance coverage for some of these tests, although it's probably kind of early, but some tests you can run through insurance, like the heavy metal panels can be done through the insurance. But we're seeing a lot of the toxins. What's not listed here is a mold, different mold, or what we call mycotoxins. They also can be strongly associated with different cancers. Unfortunately, this field is in infancy, and in addition to the non-toxic book and EWG, you're going to have difficult time finding good resources. But it's quite essential that you try to look into this topic, because often we do the most interesting cases that I've seen with cancer, with hematologic cancer, when we identified the toxins, removed it, and the patients did really well. So with that, let's shift for the last 5 minutes or so to the wellness strategies. So we're going to talk a little bit about acupuncture, Tai Chi, yoga, some of the energy treatments, massage, and then mind-body practices. So acupuncture has a very strong evidence for improving quality of life in patients with cancers. We don't have specific MDS-AA data, but we do have quite a number of articles specifically stating that all cancers, this level of these symptoms can be very supportive of. It's generally safe. You do want to make sure your acupuncturist is appropriately trained and ideally trained in specifically cancer treatments and experienced in them. Tai Chi and Qigong are wonderful energy practices. They're also gentle movements that can be very supportive for the joints. This is a picture of my Tai Chi master. I've been practicing martial arts for about 35 years at this point. And it's not necessarily an ideal exercise, or maybe it is an ideal exercise because it is balance. It trains balance, strength, and it effectively addresses fatigue, even when you're not strenuously exercising, or maybe because you're not strenuously exercising. Relatively easy to learn. Most of the retirement communities now offer Tai Chi classes. You can also learn it online, although probably this is one type of exercise you want to learn in person from a good teacher. There's been clinical trials. There's a clinical trial on lymphoma on use of yoga, and there's been some trials on Tai Chi as well, showing that there is definitely improvement in side effects of treatments and in overall feeling, quality of life. Yoga, just like, well, Tai Chi can do just watching videos, but yoga, really, you need to have a teacher to make sure you don't hurt yourself. Massage has been looked upon as an adjunct treatment. In fact, in Sloan Memorial Kettering, it's actually been used now for multiple years and showing quite significant benefit in a variety of different cancer-related symptoms. And meditation and stress, I guess non-surprising that there's a lot of data showing that it also can improve quality of life. Personally, we in our clinic, we use MBSR, mindfulness-based stress reduction program, which is a structured 8-week program. It's covered by insurance, and we're actually now doing an online classes since the pandemic with a lot of success and seemingly quite easy to do. And the benefit is actually in some way maybe even better because there's less stress. Patients don't need to get to anywhere. They can practice everything during the class and after at home. And here's some of the resources. A variety of them. This is some of the books that I've accumulated over the years. They're all a little bit different. This is Enjoy Every Sandwich is a kind of a philosophical book on how to think about cancer. Lee Lipsenstahl was a wonderful integrative medicine physician who was dying with cancer, and he reported his experience living and dying with it. This is a very advanced book by Patrick Winlin on beating cancer with nutrition. This is kind of also more of a palliative book, and a book on spirituality and mindfulness. Integrative oncology is more of a textbook, but those of you who are very interested in learning more about integrative modalities, Donald Abrams is one of the leaders of this field, although now he's retired. And Cancer Fighting Kitchen is great book if you're specifically looking for recipes on what kind of foods can be eaten for cancer. And Full Catastrophe Living is one of the original works of John Kabat-Zinn, the founder of MBSR. And with that, I want to thank my team. This is our retreat a couple of weeks ago, in person and also virtually, those of us who couldn't make it. And we can go to questions.
Thank you so much, Dr. Kogan, for all of that wonderful information. We do have a few questions. Our first question is in regards to a book called Eat to Beat Disease. The question is in regards to cocaine powder, and that has been shown to improve stem cell function. At the University of California, researchers explored whether a chocolate drink made with cocoa contain high levels of flavonols, which influence stem cells and blood vessel health.
Mhm.
Participants drank the beverage, had twice as many stem cells in their circulation compares to those that drank the low cocoa, showing that the more flavonols contained in the product and the more the stem cells benefit. They'd like to know if this could possibly be a benefit to patients that have bone marrow failure, which have
No,
fewer stem cells.
right. So absolutely not. It's the opposite. Likely going to be hurtful because unfortunately, in order for you to consume enough pure cacao, the products will have to be, it has to be an actual specific product that's currently commercially not available. You cannot obtain it from chocolate because the percent on flavonoids is minimal and you're going to take way too much sugar, and that sugar is probably going to be hurting you. You could get choco nibs and do it that way, but my take on that study and the general take on this is way too premature to say this. I think if you're consuming some amount of cacao beans from, as I said, as a cocoa nibs, for example, is totally reasonable. I wouldn't expect dramatic anything. This would be, I would consider that as a part of the wholesome diet, just like that. I don't think there's, that study basically, it's hard to translate what that increase in circulating stem cells is going to mean. And the data on actually other cancers in cacao is very mixed. In fact, there's been some even reverse. There's been concerns that this probably has to do with toxicity. Most of the chocolate you're getting, if it's not organic or cacao, are going to be heavily contaminated. And so I would be very cautious that if you're going to go this route, make sure you always get it organic. I see a really good question from Canada. So
yes, that was my next one.
Right. Canada is one of the highest number of integrative providers in the world. It's probably higher than in the United States of America, and it's a lot cheaper there. So it should be quite easy to find a naturopath or integrative cancer provider. In fact, one of our naturopaths lives in Canada and she goes back and forth. She has practice there and she has practice in DC. So don't be surprised at how easy it's going to be to find someone.
And the question was, how does someone find a professional who can help them decide which?
Look up into Society of Integrative Oncology, SIO, or Society of Integrative Naturopathic Physicians. So those are the two quality organizations, and you should be able to find somebody relatively local. Plus, remember, you can also do a lot of telemedicine now. We work with pretty much entire country. Actually, we work with all the, now we even have patients from New Zealand. Because the COVID silver lining, if the time different zones helps for you, works for you, then it doesn't matter where you are.
Thanks, Dr. Kogan.
Sure.
Our next question is, this patient has tried using melatonin, but they feel very groggy the following day.
So
is that a function of the dose?
Yes.
Or is it a common side effect?
No, it's probably, yes, it's both possible. But most likely it's the dose. You probably started at too high of a dose. You have to wait for a while. You need to start at the dose that doesn't cause grogginess, even if it's just 0.5 milligram, and then you gradually titrate it up. Yes, there is a ceiling. Some patients, even with an appropriate titration, will end up being able to take only 10 milligrams or so. So you get to the highest dose you can, and you kind of stop there.
Thank you. Our next question is there any clinical support for the supplement beta-glucan, the supplement Wellmune?
Okay, so I don't know this particular supplement. Beta-glucan is the active ingredient in most of the Asian mushrooms that we've discussed. So those of you who are interested, we are going to do an entire conference that will be open to public in June. So if you follow us at George Washington University Office of Integrative Medicine, we'll announce this soon. I use beta-glucans or specific mushroom extracts for every single cancer patient. I believe the data is grade 1. It's probably the top level evidence we have. As I mentioned, turkey tail and the chagas are the big ones. I prefer to use beta-glucans mixed with the whole extracts from mushrooms. This has to do with the fact that beta-glucan is active ingredient, but there are others. And so we think that this kind of entourage effect or synergism between different molecules is quite valuable. So I do recommend to take both. You can take pure beta-glucan that's isolated from mushrooms. Usually I don't do that. We just make sure that you get doses high enough that there's enough beta-glucans. It's a really good question. Thank you.
And our next question is, what is your point of view regarding my kind fermented turmeric blend, 650 milligram blend, NAD plus 300 milligrams by mouth daily?
All right.
And
So
astragalus.
your NAD 300 milligram PO, forget it. It's somebody is scamming you. You can't get that much. Most of the products, 5 to 10 milligrams, the NAD is highly unstable molecule. At this level of the dosing, it can only be administered intravenously. It can be done, but it's going to cost you $500 roughly a dose. So this is baloney. So not sure what's what. Astragalus is a great product for general support of fatigue and also as a recovery from chemo. I'm completely impartial to fermented turmeric. I think it's just a commercial gimmick. I think the regular turmeric is going to be just as good, but stay away from this product because NAD 300 milligrams, I'll tell you, it's a lie. You can't. It's not going to be a stable molecule. NAD plus as a pure molecule should not even be in capsule. If it's in capsules, it's a scam. It has to be in a liposomal form. There's few products that make this. The best one, actually, we're in questions, so I can say that the best ones are Quicksilver and Designs for Health, and they only supply a fraction of the dose. Most of us, when we recommend NAD, which is a good idea, we don't recommend pure NAD. We recommend NMN, nicotinamide mononucleotide, or NR, nicotinamide riboside. Those are the building blocks for NAD. So you push your own blocks forward so that you can make enough of NAD by yourself, not taking it exogenously.
Thank you
Yes,
so much.
next question is very important. In fact, American ginseng for fatigue is a standard of care. It is recommended by American Association of Hospices and Palliative Medicine and American Geriatric Society. I unfortunately don't follow regularly oncologic societies, but 2,000 milligrams of organic extract is a standard in my practice for the chronic fatigue related to cancer or to cancer treatments. And it's quite safe to combine with pretty much anything. The only sort of caution, you have to watch out for the drop in a sugar. So if you have problems with diabetes, and you're on treatment, you may want to keep an eye on the sugar. It may start going down, and sometimes we actually use it for that.
And our last question, Dr. Kogan, is do you have any suggestions for assisting with debilitating fatigue that occurs with a patient diagnosed with proximal nocturnal hemoglobinuria, PNH?
Of course, yeah. So definitely American ginseng, and then several other adaptogens that could be very useful. Astragalus can even be used for that. Somebody asked that before. I think the acupuncture can be a wonderful choice, and also Tai Chi and Qigong. So this very gentle movement that actually very energy building. Cancer-related fatigue is the most common side effect, not just from treatment itself, but side effect of the cancer itself. And I think that the integrative modality is a wonderful there. They're probably one of the few things that are gonna work for you. There are other things that we often utilize. They get more complicated. So the NAD treatments or NAD plus boosters, so nicotinamide riboside or NMN or nicotinamide mononucleotide are worth considering, but do not buy any oral NAD. That's a scam. There's unfortunately a lot of really, there's so many supplements. There's upwards of 100,000 products out there. I would say probably more than 75% of them have no value of any kind. It could even be toxic because they could have contaminants. So with that word of caution, I hope everybody have a good day. Again, thank you so much for inviting me, and good luck.
Thank you so much, Dr. Kogan, for sharing your time and your expertise with all of us today. And if you'd like to watch this webinar again at a later time, it will be available on our website within just a few days. If you have any additional questions, please feel free to send it to us at any time within 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, or submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 39 years. This concludes our program. Thank you again, Dr. Kogan. Have a great day.
Thank you very much. Bye-bye.